Okay, I think we'll make a start. Welcome everybody. Sorry we're a few minutes late. We had a slight technical hitch due to an auto update, but we are with you. We will finish on time though, because I know people will have managed their energy to be with us today. Just to let you know that it's being recorded so that people who are unable to join today can access it afterwards, or indeed to be able to watch it in short chunks. I'm really delighted to welcome everybody to the webinar, but also to those who are watching live on Facebook, and to our medical advisor, David Strain, who will be talking to you in a little while. For those that don't know me, my name is Sonya Chowdhury. I'm the Chief Executive of Action for ME. And I'm just going to start with a short introduction that makes up for the forward look that we missed at the AGM. Unfortunately, I was ill and had to leave the meeting, so I wasn't able to give this then. After that, after I shared a few slides, David will then talk about long COVID and ME. And then we will have an opportunity to hear a little bit more about the work that Action for ME is planning. And then we've got a Q&A. We've got several questions that have come in already. You can post questions on Facebook, on Twitter, and also through the chat if you're joining us through the webinar. So I'm just going to start by reminding those of you that joined the AGM about some of the work that we've done in 2020, 2021. All of this can be found in the annual report. I know the picture isn't very large, it's just there for illustration purposes only. As an organisation, we provide an information support and advocacy service to children and adults with ME and also their families. And as you will see from our annual report, we worked with over 1,700 people through our phone and email information and support service, nearly 170 children, young people and families, and 53 people received one-to-one advocacy. That number is much smaller than we anticipated because the level of complexity and need that those individuals had was much higher than we had anticipated. And a large number of those individuals have very severe ME. So we've been alongside people for a long period of time. I'm not going to repeat all of this because this was covered in the AGM, but I wanted to give you a flavour of some of the work that we do. We also have been involved in medical education work. Over 600 health professionals have accessed the CPD module that Dr. Nina Muirhead has produced. And in fact, David and others have joined my colleague Ruth for some of those podcasts. We've done a lot of work with the press and the media, and many of you will have seen the result of our work in August and early September through various press briefings, and we've managed to secure quite a bit of coverage in a number of different press and also in a number of different media as well. We're also involved with research. We fund research, PhDs and fellowships to bring new researchers into the field. But we also work collaboratively to catalyse funding for research, and that has led to the funding for the Decode ME study, which we are delivering in partnership with a group of people who are PPI group, the Patient Public Involvement Group, and also the University of Edinburgh. We're also leading the priority setting partnership, which will produce hopefully the top 10 research priorities as identified by people with ME, their carers and clinicians. And that should come out around March, and we're just about to launch the second consultation. So we do hope that people will take part in that. Next slide, David, thank you. Great, I've got my assistant here on hand. As many of you know, we're looking to merge, and we announced that recently. We did have a merger Q&A last week, so I'm not going to go over a lot of that. It is available online if you missed it. But we are frustrated at the lack of healthcare services available for people with ME, both children and adults. And even with the services that exist, and I know some have mixed experiences with those services, some have great experiences, some have really negative experiences. But even with the services that exist, it simply is not enough, and it's simply not good enough. The ME Trust provides a whole person service through a doctor, physio, nurse, counsellors, and multi-faith chaplaincy. And together we feel that we will be able to scale up the services they provide to be able to meet more need and to be able to do that more quickly than we're going to see elsewhere. That doesn't mean that we're not going to be lobbying the NHS and others to have more services in place, but we want to demonstrate the different ways that services can be provided in a very holistic manner. And I think having David working with us and being able to advise on some of that is going to be fantastic. Thank you. That brings us on to ME and long COVID. So what do we say as an organisation? And many of the questions that we've had that have come in already around our positioning on ME and long COVID. We are a member of the Long COVID Alliance, which is run by our partner Solve in the States, and my colleague Sam has been leading the international working group. We have said from the beginning of the pandemic that one of our big concerns was that we would see an increase in ME as a result of post-viral illness after COVID. And indeed, that is what we're seeing. We're seeing an increase in people who are being diagnosed with ME, or an increase in people with ME-like symptoms. Not everybody who's had long COVID or has long COVID has symptoms that are similar to ME, and we don't yet understand enough about long COVID. Indeed, we don't understand enough about ME or other post-viral illnesses as a result of the lack of research investment. And David's going to talk about that a little bit in a minute. But what we do know is that ME has been ignored for generations. We have seen that not everyone who has COVID-19 recovers, and many of them, not all, as I said, experience symptoms similar to ME. So this gives us a really unique opportunity to understand why some people recover and others don't. And not only does that help long COVID, it also helps other post-viral illnesses like ME. And what we really need through our work, there's a petition that we've got going at the moment, which we'll share the details of a bit later. We really need to secure a little bit more investment to make sure that the money that's gone into long COVID research also benefits other post-viral illnesses like ME. This is, the greatest scientific opportunity that we've got. None of us would have wanted the pandemic or people to be harmed, died, or ill as a result of an infection, COVID-19. But we are living with what we've got at the moment, and we must make sure that we don't lose this opportunity to gain that insight. And we need to be able to work together to be able to secure that, not just as ME charities and supporters, but actually working with other post-viral illness groups. So I'm now going to hand over to David, who's going to share with you a presentation that he gave very recently. Over to you, David. We can't hear you, David. David?
I've got a dual mute system, and of course, unmuting one button, I forgot to unmute the other button. Sincere apologies. Thanks for that introduction, Sonia. For those of you who don't know me, my name's David Strain. I'm a clinical senior lecturer at the University of Exeter Medical School, and I've recently been honoured to be asked to be the medical advisor for Action for ME. This is on the background of being the physician who supported a CFS and an ME service in the Southwest for several years before the COVID pandemic. Then in the aftermath of the pandemic, as we started to see long COVID arise, I started seeing patients who had what was effectively ME presenting to my ME clinic that was entirely triggered by COVID. That's when we first started talking about it. And therefore, when the NHS Long COVID Task Force was established, I was put forward by the British Medical Association to be their representative. Because a lot of what we're seeing in long COVID has been seen for decades in ME. Now, I know we've effectively got two very similar audiences watching this. There's those who've been suffering with ME for decades and been crying to have it recognized for the debilitating illness that it is. And then we've got those who've got long COVID, who are just coming to this, and for many have actually been reluctant to accept that long COVID could be a parallel disease to ME. And actually, that's the first point we want to raise. When long COVID, when the organisation support groups came about, they did want to distance themselves from ME. And that was in no small part because the stigma that this diagnosis has carried for decades. And that's something that we're going to be working hard to break down. And the long COVID alliance that we're seeing coming out that is welcoming the various ME support charities to work with highlights the fact that this is a recognition that the two diseases have got a very similar presentation. And therefore it makes sense to find out, do they have similar underlying causes? For those of you approaching this from from a long COVID task force, these are the hallmarks of ME. It is the post-exertional malaise. It's the severe worsening of the symptoms after cognitive or physical exertion. And actually, this is something that those of you with long COVID will be very aware of. You can actually feel the muscular pain after doing lots of mental exertion. There is the cognitive dysfunction, the so-called brain fog. People who've previously been highly functional now struggle to keep up with the kids when it comes to working the computers. Then there's the headaches, the pain, the shortness of breath, the generalized fatigability, sensitivities to light, sound, touch, to different foods, the strong smell that some people are experiencing compared to the complete lack of smell that other people are experiencing. The name chronic fatigue syndrome was actually coined by the Centers for Disease Control in response to an outbreak of a chronic flu-like illness in Lake Tahoe back in the 80s. And that actually was probably the worst thing to happen to myalgic encephalomyelitis, because the whole name chronic fatigue does not encapsulate the severity of these symptoms. In many ways, that's one of the reasons that the long COVID, people suffering with long COVID have been reluctant to be associated, because this is not just about fatigue. This is a multi-system disease. This is something that affects every part of the body. And there are many different criteria that people talk about. So there's the Holmes criteria that were modified to become the Fukuda criteria, then the Reeves criteria, we've got Canadian consensus criteria, and they all share the central tenet that there is a disproportional fatigue. Also, that all a diagnosis of exclusion. You do not have ME or CFS if you've got an underactive thyroid gland that's making you tired. You do not have CFS and ME if the underlying reason is depression, because being depressed will cause fatigue, but that is not ME. That is not CFS. Now, that is a very difficult overlay to entwine, because basically many people suffering with ME will effectively experience a grief reaction. They will see their children growing up and knowing that they can't play in the park with them. They will see their family go through these landmark events and feel that they can't participate in it. Therefore, anxiety and depression is very common in people with ME. But it is very important to establish the order. People who get depressed and feel fatigued have got depression that has an underlying cause that can be treated. People who get CFS and ME and miss those family developments are understandably depressed because they are missing their daughter's graduation, their son playing football in the park, or whatever it might be. But that is not the underlying cause. And that has been one of the biggest difficulties that people have faced. And actually, that's one of the biggest difficulties with some of the work that's gone on. There's one other criteria for diagnosing CFS and ME that I've deliberately left off here, and that is the Oxford criteria. And the key difference there is that criteria did not exclude some biological conditions, did not exclude the non-physical brain disease. And therefore, the Oxford criteria would have included those people who have depression and are tired as a result of it. It would have excluded many, it would have included rather many people with other non-biological causes of fatigue. And that's a very important distinction in just a moment. Because actually, this whole chronic fatigue syndrome, this whole name, well, it causes problems in its own right. Actually, Anthony Kumarov, who is the chap who was first to give this name, he's the person who coined the name after that outbreak in Lake Tahoe, gave an interview with the CDC on their public health ground rounds, a very common phenomenon where you get these people who've made a traumatic difference to a disease, just to give an interview about how that disease has progressed since they got involved. He declared that was the biggest mistake that he ever made in his entire career, to call chronic fatigue syndrome, because it trivializes and stigmatizes the illness. It makes it seem unimportant, possibly not even real, because everybody at some point in their life has experienced fatigue. And therefore, they find it difficult to draw a line between the fatigue that you might feel from having a 3-month-old baby, or from having too much work to do, or having everything else going on, from this biological disease that causes the aches and pains that, well, that many of you are familiar. And that brings us on to how we can start working together with long COVID and the ME community. Because actually the underlying cause of ME is thought to be post-viral. It's thought to have an autoimmune cause. Epstein-Barr virus, glandular fever, is the most commonly implicated, but many other viruses have also been implicated. But there are many things that are similar between ME and long COVID. For example, people with chronic fatigue syndrome and ME have been demonstrated to have lower levels of interleukin-16, interleukin-7, vascular endothelial growth factor. These are all those key markers, these key measures of inflammation that we know are triggered in COVID. There's a dissociation between the cytokine regulatory networks. So the cytokines they're basically just the messengers that go between cells to cells. Again, something that has been highlighted to take place in acute COVID. There are specific genetic components that predispose people towards ME. And they are in the TNF, the tumor necrosis factors, and the interferon gammas. And again, both of these have been implicated in acute COVID and the cytokine storm that is still killing younger patients. ME has been seen to cause small vessel disease within the brain. Those small vessels, they're the capillaries that are delivering the oxygen and nutrients to the tissues. That's been demonstrated on the MRI in ME. And actually, we are rapidly seeing very, very similar changes in the MRI of people who are experiencing long COVID. So there are some dramatic similarities. And because of that, there's been a lot of call to try and draw on the knowledge that we have from ME when it comes to putting together studies in order to build the best platform to treat long COVID. However, this is where life gets difficult. Because to date, the only big study that's been done in ME is the PACE trial. Now, we know there are lots of smaller studies, but this is the largest. And one of the many problems with this study is the criteria they used at the time was the Oxford criteria. That criteria that I mentioned that specifically did not exclude people who had other causes of their fatigue. Those who might be living with depression or anxiety or many other causes. So it included those people within the study. Now, I want to stress, this is not a criticism of those investigators who actually set about this in good faith when they did so. At the time, they were given advice. With retrospect, that was wrong advice. And they've acknowledged that, that this has been a key problem with it. Because the advice that they had at the time led them to recruit people who, well, basically did not have what we would today is called myalgic encephalomyelitis. Now, the key outcome they reported at the time was that 22% of people returned to normal when they get the cognitive behavioral therapy and or the graded exercise therapy. And only 8% of people got that with the usual care and the APT, the adaptive pacing therapies. They also reported no adverse outcomes at all. However, that's the bit that's triggered the most problems down the line. You see, what they reported is 22% of people are returning to normal. And what they regarded as normal was actually lower than the entry criteria to coming into the studies. Now, it's important to say that the population that they studied was predominantly in the 35 to 45. So their exercise levels should have been scoring somewhere around an 85 to 95. What they regarded as normal was 60, and the entry criteria to get into the study was 65. Therefore, saying that this is a positive outcome is, at best, a misrepresentation. However, this has caused the greatest amount of controversy within the ME community, because many people with true ME, many people with post-exertional malaise will tell you that if they exercise, it takes them longer to recover from the exercise than the benefit that they get from that exercise would last in their body. If you imagine you do an exercise and you'd expect to feel better for 3 days after your exercise, and therefore if you exercise again within 2 days, you'll feel better. And if you exercise again within 2 days, you'll get stronger and stronger and stronger. If you're living with ME, if you did exercise, it would take you 4 or 5 days to recover from that. The net result of that is all the benefit from the exercise has gone, and actually you've lost a bit more of your fitness while you were trying to recover from that exercise. As a result, when we survey people, when we speak to people who've gone through this graded exercise therapy, the vast majority tell us that it causes more harm than good. As a result, studies into long COVID are rapidly losing the exercise arm, far more aligning themselves to adaptive pacing therapy. Now, I'm stressing that that is for the particular sort of long COVID that looks very similar to ME. There are many people who are experiencing what we call long COVID who've actually got the sequelae of the severe initial COVID infection. They've got the sequelae of inflammation on the lungs, inflammation around the heart, causing shortness of breath and palpitations. Now, for many other people who've had ITU admissions, for them, graded exercise therapy is really useful. And therefore, if you have the post-ITU syndrome version of long COVID, it is entirely appropriate to try graded exercise therapy. If you've got the myocarditis, where has also been demonstrated benefit, again, entirely appropriate. But if you're in a position with the ME, CFS, manifestation of long COVID, then the adaptive pacing therapy is probably the most beneficial. What else do we know? Well, when it comes to other treatments, there are very few other treatments that we actually have for the treatment of ME. There's been the use of the H2 antagonists that in small studies have demonstrated benefit, but only in very small studies. They don't meet the rigor of the randomized control trials elsewhere. Actually working in long COVID is an opportunity to try these. And it's hoped that at least one of the studies, the Stimulate ICP study that's looking at an interventional study, is going to be testing this in patients with long COVID. There's some low-level research looking at modifications of the microbiome. It's been highlighted that the family units are likely to get ME at a similar time if they are exposed to the same virus. Now, a husband and wife have got no genetic links. Therefore, if they both got the same disease at the same time, that implies there is some sort of underlying environmental aspect. And the bugs that live in your gut actually determine your response to many different invasions. Theoretically, it's possible that the virus that triggered your ME or your long COVID is still alive and active in your gut, immunoprotected, but sending out lots of inflammatory mediators from time to time that cause this relapsing remitting conditions. There's other therapies such as low-dose naltrexone, there's rituximab, there's aripiprazole. Many other therapies have been trialed. The problem is most of these are in small numbers. So what does the future hold? Well, one of the first things we want to do is to try and get comparisons between long COVID and ME to look for the similarities. Because if it turns out that there are some similarities in those inflammatory mediators, even in the underlying genetics, in the microbiome, might be at least transplanted, might be translated into other diseases. Results from studies looking at vagal nerve stimulation, for example, in long COVID, might be able to be trialed then in ME. The first point of that is bringing together the studies that are very similar, looking for those similarities. So, for example, I was already the chief investigator of a study called SanoGold. It's a study with Sanogenetics that looks at the DNA of people who've got long COVID. If anyone is watching this who has long COVID and would like to participate, just search for the Sanogenetics website. It's the GOLD trial, Genetics of Long COVID. We'll send you the kit out, whether you've still got symptoms or whether you've got improved, and then we'll be able to look at your DNA in exactly the same platform that the Decode ME, the Action for ME study that Sonya was talking about, is looking at the genetics of people with myalgic encephalomyelitis. The hope then is if we can start seeing similarities in the genetics, then actually this is good evidence that these are similar diseases, just with a different trigger. So, in summary, there are many people that believe long COVID is a form of ME that just so happens that we know what the trigger is. This belief is a belief only. It will be great once we get to a stage that we can confirm whether they are the same, or we can say that no, they are different. They just so happen to have different presentations. But this is a golden opportunity to extend the research that's being done, the millions that's being invested in long COVID services, and to look at that to say, okay, if we're doing this study, let's extend this to people with the ME. Let's find out if these two diseases do behave the same. Let's find out, can we see a recovery for those people who've been struggling with this disease for decades? Because the likelihood is that ME and CFS is not really one disease. The likelihood is that many of you will be experiencing some, but not all of these symptoms, and there'll be 2 or 3 different diseases that all cause a similar presentation. If we can identify the different subtypes, then we can start looking for specific treatments. And then we can start looking at extending those interventional studies. We can start looking to say, right, we are doing a randomized controlled trial of drug X or vagal nerve stimulation or whatever it may be. And then let's see expanding that to a different group. All of this is going to require good, positive communication. People living with ME have been left to one side. They've been stigmatized. They have been rightly upset by this. Now is the time to come out, to apologize and say, what can we do to help fix this? Back to you, Sonya.
Thank you, David. I've been following some of the social media. People have found that fascinating. So really appreciate you taking the time to share your presentation with us. As I mentioned earlier, I'm just going to give a very brief overview of some of our thinking about what we're going to be doing as an organisation over the next 5 years. I should say that this is emerging. This is not set yet. We've had a number of discussions as the staff team, with our board, with people that we work with that engage with us in a whole variety of different ways. And we looked at the results of our big 5-year survey, where over 4,000 of you told us about the things that are working well, and more often than not, the things that aren't working well. We are a small charity, just over £1 million, and whilst we might be large compared with others, we're actually very small in terms of the level of need out there. And our advocacy service has had a several-month waiting list because of the demand for that. And so we know that we need to be able to invest more over the next 5 years. But whilst we're providing support services, we also need to think about the change that we create for the future. Several people I have heard have said, if we had put the money that was needed into research, into ME 30 years ago, we will have been a lot further forward in terms of our understanding regarding long COVID and potential treatments. And I think we have a moral and ethical duty to ensure that things change. We can't wait another 30 years. 5 years is long enough. And as a small charity, we're not going to be able to do everything that is needed. David, I think there are a couple of clicks on here. Yeah, John just put all 3 up, and that's fine. Thank you. So we will, as an organisation, continue to work to improve lives now. We know that through our information support and advocacy service, that is a much needed service, and we need to do more to better reach those that are currently underserved. We do work with a large number of people with more severe ME, but actually we're not meeting enough need there. And we have a lot more to do to reach people from Black and other minority ethnic groups, for example. So we will continue to invest in those services and to grow them so that we can reach more need, and to try to do that more quickly. That will include merging with the ME Trust and ensuring that we can continue to invest in those healthcare services. We have put money aside to do that, and we have invested over this last year to grow our services. So you will have seen a number of vacancies that have come up, and we want to continue doing that. That remains a priority. But we also have to make sure that we invest in the future and that we invest in change. So research is going to become a much bigger area of activity for us. We want to invest in the early stage career researchers. We don't have the multi-million pounds that are needed for the big levels of research that David touched on and other research that's needed. So we need to be very strategic and careful about what we do with the relatively small amount of funding that we have. What we have seen is that we are good at working with others, that we are good at influencing in the background to try and create the funding, the leveraging the funding that is needed for the research like Decode ME, but that is not enough. And we have a responsibility that when the priority setting partnership identifies the 10 priorities in March, we must work together to ensure that we see those research priorities funded. It's not going to happen immediately. I think we all know that these things take time, and many of us have been advocating for years to get the level of funding that we've got now. But it has to be quicker, and we will invest in doing what we can to ensure that happens. The Priority Setting Partnership was unusually funded by the National Institute for Health Research, the Medical Research Council, and the Chief Scientist Office in Scotland. That's government funding in effect that's gone into that. So we have to ensure that government funding, mainstream research funding, follows for those priorities, whilst we also work to invest in the new generation of researchers. We will also continue to ensure that our policy and education work ties into our health and wellbeing investment and our research investment. we will have to be quite choosy about what we do and what we don't do, because if we try and do too much, we will spread ourselves too thin. And that will mean that there'll be some things that we won't do, and that will upset some people. And there'll be other things that we do, and we hope that that will be welcomed. We are in the process of putting together our kind of plans for the next 5 years, and we will be engaging with our stakeholders, those that use our services, our supporting members, our donors, etc. We have continually put out information, but we do welcome the opportunity to engage with you directly. We have a patient reference group, we've got lots of young people's groups, and we will engage with them directly around the detail. But if you wanted to be involved in that, then please do drop us a line, and we will happily put on some closed sessions to share with you what our thinking is, for you to have an opportunity to critique and test us. We need to know that we've made a difference in 5 years' time, and we want to make sure that what we deliver has an impact. Thank you, David. If you're happy to stop sharing the screen. We're now going to take some questions and answers. I'm going to try and get through as many as possible. We've had quite a lot that have come in. So the first one is, what is Action for ME going to do to ensure that the severely affected are not just tagged into the little mainstream ME research that's happening, but is recognised as a priority and studied in its own right? I think that's a really good question, and it's something that we have been grappling with. There is very little research specifically around the severely affected. We're working really hard with the Decode ME study to make it as accessible as possible. And I anticipate that we will see the output from the priority setting partnership, that we will have the number of the 10 areas of research, but that we will also be able to break down the responses that we've had, so that we can understand what responses we've received from people with who are more severely affected. The key is bringing in researchers that are willing to do the research and understand how to undertake research with those that are severely affected, and for us to continually lobbying for that research funding to be made available. David, I don't know whether there's anything you want to add to that.
Yeah, it's a really important area, and as with every disease, there are grades of the ME, and it's tremendously difficult to actually get to the people who need this research most. Being involved in research, so my day-to-day job, I work as 50% a clinician, 50% of a researcher, and I know how demanding it can be to be part of a trial. So we're going to need a new generation of studies. We're going to need studies that can actually work within an individual's energy envelope, but still include them in the research. Otherwise, we'll end up extrapolating from an entirely different population. They are being looked at. There are groups that we've been in contact with in the States that are working on very specific ME groups, ME therapies rather. There's groups that we're looking at with non-invasive vagal stimulating to try and improve the energy envelope for the people. And actually, for those sorts of studies, we are specifically looking at studies that can be built around those who are the most severely affected, because that's the group that have been excluded from just about everything up until now, and therefore this is the population that we really need to be reaching.
Great. Thank you, David. The next question is, what is Action for ME going to do to get State Medical Research Council funding ramped up from the hundreds of thousands per year to the millions we deserve and have needed for decades? As some of you will know, we work as part of the UK Research Collaborative for ME, which David has just taken over as chair of. We've got our first meeting, finally been able to set a date in November. So we are continuing to work with the mainstream researchers, the MRC, the NIHR and others, to ensure that we get the funding that's needed. I am fully aware that it's not quick enough. I don't think anybody I speak to believes that it's happening quick enough, and it's wrong that people have been left for decades without the level of research investment that's needed. And that's despite there being calls on the limited funding that's available. It's simply just not enough. We will continue to work in the background. That's not always seen, but our approach as an organisation is to get alongside people and to try and work together to create that change that's needed. As research is going to be a greater priority for us over the next few years, you should expect to see us increase our activity in that area. Next question is, I'd like to know going forward how our ME charity is going to ensure that people with ME and ME itself and severe ME are researched as much as long COVID. And we've got several questions around that. David, do you want to start, and then I'll add something to that?
Yeah, so as Sonya says, we've been campaigning and we will continue to be campaigning from at a government level and every level between there and the on-the-ground researchers. We are actively involved with some of the long COVID research programs. And even within that, we've been facing stigma. There has been one or two of the research programs that didn't want to start drawing parallels to ME because they were afraid of being seen to be associated with a disease that carries so much stigma. That has been addressed head on. There's been there's been no punches have been pulled in doing that. This is a very timely opportunity to do something that should have taken place 40 years ago. And we've openly said, if we'd have done this when it was necessary 40 years ago, we wouldn't be in the state that we're in at the moment with long COVID. So we're addressing this head on. We've been campaigning through Parliament. We've been campaigning directly on doorsteps, engaging with groups like the NIHR. The presentation I've just given, I gave to the NHS Long COVID Task Force, the head of the group who gets to make the money decisions regarding money within NIHR, to start saying this is the opportunity to do this. We do have to point out that there are no promises from this, that the government and the research organisations sat alongside them are in the current position that they are out of money. They are struggling to keep the universities going. They're struggling to keep the researchers going that they've already invested in. This is a long game. There are not going to be any quick wins. They're not suddenly going to turn around tomorrow and give us the millions that we need. But by being there, by being at the forefront, by being recognised that this is a big need, that we could have averted the long COVID catastrophe, means that next time we'll be right at the forefront when it comes to where the research is required.
Thank you, David. And just to remind everybody, we do have a live petition at the moment. I've just asked Sam to see if he can put that up for us through the transcript, and we'll make it available on our website, etc. as well. That petition is still live. Somebody's asked what's happening with it. That's open for at least another month. And the plan is to, as soon as we get to 10,000 signatures, to be able to deliver that to number 10. Will the petition have an impact in its own right? Probably not, but we should be able to create some profile and coverage as a result of that. And the more coverage that we can get at this stage, the better. We will also be working and encouraging the other ME groups to help us promote that. Our focus has been on the NICE guideline at the moment, quite rightly. I've got so Sam's just shared the link. Hopefully those of you on the webinar can access that. I'm going to take a few that have come in from those live at the webinar. Re-CFS being an unhelpful name, I think all of us would agree it's an unhelpful name. The question is, how do we get rid of it then? And just as an aside, David wants to say that it's worth noting that many of us have been unable to have a son to miss playing in the park with, or a daughter to miss graduating, because ME has stopped us becoming parents in the first place. And sadly, that's something we hear a fair bit of. So how can we get rid of CFS, David?
Yeah, it's a really important one, and I agree entirely. So firstly, I do apologise. Those examples that I used were just first examples that things, but this is a disease that has affected so many lives in so many different ways, from childhood right through to adulthood. I think the first step in addressing it is actually for us to start using the name ME in full. To start talking about myalgic encephalomyelitis rather than even just ME, CFS. Always happens in the live webinars. My daughter will be making an appearance in a second, I'm afraid. But talking about it in full, actually saying myalgic encephalomyelitis when we're referring to it, not just ME. The CFS ME moniker becomes something that can be used as a shortage. Okay, I'm going to have to do this because otherwise she won't go away. Say hello to everybody.
Hello.
Thank you.
With your iPad.
Apologies, chaps. My wonderful daughter has managed to figure out how to break through the lock in my office.
Very resourceful.
Yeah. So it's using the name, and for us to start using where we see CFS-ME or ME-CFS to actually start saying it in full. It is myalgic encephalomyelitis. It's a mouthful. Doctors have managed to get around terms like dysdiadochokinesia and amaurosis fugax. If they can deal with nonsense names like that, they can say the name in full. And once we get used to people saying the name in full, this is, and myalgic literally means causing pain. Encephalomyelitis means inflammation of the brain. This is inflammation of the brain that is causing physical and mental pain. It needs to be addressed as.
Thanks, David. I think you might have been muted by some helpful hands there in the background. I think that's a really important challenge to us, and it's one I'm going to take away, and we will talk about as a team and can consider that, because I think it's something that we can all do and create the change through that. The next question we've had is such a good overview of ME. Will this be available online afterwards? And it will be available on the Action for ME YouTube channel, I think, and you'll be able to share that as widely as you like. We'll also promote it on social media. The next one is around subgroups of ME. This is probably a David question. What if you literally have all the symptoms on every list of symptoms? Does that mean you have more than one type of ME, particularly if there's more than one point of worsening following a different trigger?
It's very difficult to fully understand this, and we're just getting down to the grounds that there's not enough research that's being done. It is, if we were to go back 50 years, there are subgroups of people who would present with muscle pains and weakness and fatigability, and 50 years ago they would have been said to have ME, but now we know what the antibody is that's caused them to have a disease like multiple sclerosis or myasthenia gravis or other diseases that we now have underlying causes. And actually, when we track it back, even multiple sclerosis is associated with a post-infection condition that they're starting to identify what the infection was there. I think as we move forward with medicine, we will find out that there are people who are more prone to developing this, and they may have multiple different versions with multiple different triggers. Remember that COVID-19 belongs to the same family of virus that gives us the common cold. Now, I defy anybody to say that at no point in their life have they had the common cold. We don't know which are the different triggers for different people. And if you're susceptible to it, it may well be that different viruses have all given you different triggers. Or it could just be that you will have one particular version that is going to be identified at some point in the near future. What we are really hoping is going to come out of this, and the first thing we're hoping for, is some form of diagnostic test. Once we have a diagnostic test, then it moves away from this, you've got nothing wrong with you because all the tests that we've got have said that they're normal. That's not a failing of the person with the disease. That's a failing of the medicine. And once we have these quantifiable tests that can say, yes, this is what you've got, this is why you've got it, that's a massive step towards knowing how best to treat it. But importantly, that effectively obliterates the stigma. Nobody has stigma today with multiple sclerosis because you can do an MRI that identifies where the problem is. Yet the stigma still is attached to ME because the inadequate tests are not able to identify where the problem lies.
Thank you, David. And I'm just going to add, there was a part of a question here which we haven't touched on, is when does finding treatments urgently become part of a 5-year plan of UK charity for the patients they represent? The reason we want research is for exactly the reasons that David has outlined, that there is then a diagnostic biomarker test and to see treatments, and not just treatments, but personalised treatments, and an understanding of the different phenotypes, subsets, however we want to classify that. So another question here, how will you work with long COVID charities to put ME higher on the agenda? Both David and I are working with long COVID charities. I mentioned earlier, we're part of the Long COVID Alliance, and we're in discussion at the moment about what more we can do with long COVID charities, but also other post-viral organisations. So there'll be more news on that in the future. There's a question saying, why don't you respond to the negative news articles? I'm sure many people have seen the Telegraph this week. We don't always respond to negative news articles. We have to be picky and choosy about what we do and what we don't do. At the moment, I have no comms team whatsoever, so our comms capability is limited. But also, sometimes by responding to things, you keep them live and you keep them active, and that is not always helpful. So the Telegraph one this week, we've been in consultation with the other charities through Forward ME, and many of us have shared the view that actually doing nothing is the right thing to do. We do not need to waste our time fighting against individuals that have specific views that are not helpful. We need to focus our time on the things that really matter. Question about the universal credit uplift and what is the update on this? So just to say, we're working with the Disability Benefit Consortium colleagues on a campaign to cancel the cut of the £20 uplift and to increase legacy benefits by the same amount so they're not left behind. And in fact, there's actually a High Court hearing today looking at this, and the Disability Benefits Consortium, of which we are a part, are protesting in London. The next question is, can people donate to certain types of research through Action for ME? Yes, you can. There's something called restricted funding. So if a donor says they want money to go to a specific cause, as long as we accept that we can deliver that, then that money has to be used in that way. And we're actually independently audited every year to make sure that we spend the money in the way that we say that it's going to. And a number of our different services and activities are restricted in that way. We also need money to keep going and to do the things like paying people and, managing those kinds of things. So we do need a mixture of funding. Next question is, will you move away from just ME and cover long COVID too? As an organisation, we do not ask for people to prove a diagnosis of ME or to even have a diagnosis of ME. If they have ME-like symptoms, believe they have ME, or have been told by a doctor they have ME, then we will provide a service to them. We have no way of proving one way or another, and we know that diagnosis, misdiagnosis is a major issue. And our surveys have shown that people can wait for years and years to even get a diagnosis. So if somebody believes they have ME, has ME-like symptoms, or indeed has the diagnosis, whether they have or haven't had long COVID, we will continue to work with them. I'm going to finish, we're getting close to time. We've had a thank you for doing the webinar with closed captions. It makes such a big difference. Please keep doing this for future. We will. And then the sort of 3 questions here around the vaccines. David, I'm going to pass to you. Why is everyone ignoring the devastating adverse reactions of ME and long COVID patients to COVID vaccines? Why are you promoting the vaccine as a treatment for long COVID while continually ignoring those who have deteriorated? And you must represent all patients, not just those who get better with the vaccine and get you excited.
Yeah, that's a very important point. I was involved very heavily in a study that was done by one of the long COVID support groups, finding out what the impact of vaccination was for those people who went through the vaccination. And for those of you who've not seen it, what we showed is that 57% of people got better, about a third of people had no difference, and 10% of people actually deteriorated. That was picked up by some of the the news outlets to talk about how we were actively promoting vaccine as a treatment. First thing to say is they were all people with long COVID. Actually, we did a separate small group of people with ME, and as our attendees suggest, that actually as many, if not slightly more people with ME got worse than got better, and particularly with those live attenuated viruses, the Janssen and the AstraZeneca. But the other thing is that what we wanted to do on the back of that was to do the research to find out if we could predict who is going to get better and who is not going to get better. Who's going to get better with one particular vaccine? Because if you could get better with a vaccine, actually whatever's making them better would be a research strategy. Similarly, what makes people worse? Because if you're one of the people who actually your ME or your long COVID gets worse after a vaccination, that is telling us something about your immune response. It's telling something about what's causing you to get unwell, and therefore enables us to try and find out a solution, try and find out a cure to improve the symptoms. Unfortunately, as you say, this has been the headline for the newspaper is doctor says everyone should be vaccinated. That is not what I was saying. I do believe people should be vaccinated, but that's not as a treatment for long COVID. That's because if you get another variant of COVID, if you've had the Alpha and you get the Delta, that will have a devastating impact. Patients with ME who've gone on to get COVID have had a massive deterioration in their ME symptoms. We've seen that. But that isn't, I am not out there saying this is a solution. I'm saying this is incredibly interesting, and this is something that we need to explore, both to provide treatment options for those who do benefit, and also to find out why some people deteriorate, because that might give us a treatment option going forward.
Thank you, David. We've managed to get through all of the questions bar one, which I'm just going to sneak in, which is, why isn't ME talked about in Parliament and what are you doing to change that? It is talked about in Parliament. We do work with MPs to feed questions and ask them for support. And as part of Forward ME, there is a lot of activity around that. And you can keep an eye on our website and social media to find out more there. So I'm just going to finish off by saying there are a number of ways that you can get involved. And for example, you can share this film and help promote understanding around myalgic encephalomyelitis. We have the petition that is live. We would really welcome you sharing that with us. I mentioned the priority setting partnership interim consultation that's coming out. Again, you can participate and help share that. And if you want to get directly involved, I'm mindful of the funding question, do talk to us if you want to donate. You can become a supporting member. You can get involved in our Big Give Christmas campaign. There are lots of ways that you can get involved. And also, if you want to engage with us around what we're going to do over the next 5 years, then I would love to hear from you. David, thank you so much for your time. You're always very generous and say yes to everything that we ask. And I know that it's not just us that really appreciate that. There are many people that have been listening and out there that really appreciate you standing up and speaking out on our behalf. And I also want to just say thank you to my colleagues who are working in the background on social media, doing the tech, etc. They're absolute stars, and none of this would be possible without them. Thank you very much. I hope that you've been able to take something away from today, and I look forward to you joining us on our next webinar. Thank you. Bye-bye.